Well, hello, and really thank you for inviting us to be part of your National Arab American Association meeting. We regret not being there with you in person, but thankfully, because of technology, we're able to come to you via Zoom. So thank you for inviting us to be part of your program. My name is Cgadi Oberley. I'm a medical oncologist, a hematologist, and I am currently at Caris Life Sciences. I'm the chairman of the Precision Oncology Alliance. It's a large collaborative research network that we have at Caris with many academic institutions across the country and the globe focused on precision oncology and biomarker research. I'm very delighted to have with me my colleague and friend, Dr. Matt Oberley, who will introduce himself. And we are going to really talk a lot today about liquid biopsy. What in the world is liquid biopsy? Why do you care? And why should we all care about it? Matt, thanks for also joining me, but let's introduce you to our viewers.
Thank you, Cgadi. Well, I'm actually also an employee at Caris Life Sciences. I'm the executive medical director at Caris. I'm a trained pathologist. I subspecialize in hematopathology. And I'm responsible for the overall quality of the testing emanating from our laboratory. So today I'm in Phoenix, Arizona, where our primary clinical laboratory is located. Happy to talk about liquid biopsy.
So Matt, the first thing that comes to my mind, honestly, is like, why do we even call it liquid biopsy, right? I mean, it's liquid, it's blood test. Why is it, who invented the term biopsy? You can't really biopsy the blood.
Yeah, I agree. It may not be the best term, but I've actually come to adopt it. Really, if you think about what process we're trying to emulate here, it's trying to recapitulate the gold standard of diagnosis for any patient with cancer. Right now, that's done on a tissue biopsy. So we get tissue from patients for diagnosis, for determination of the best therapy for the patient, and from following the response to therapy over time. And so really we want to be able to recapitulate all these activities from a blood specimen because it's so much easier to get blood. And now the technology is advanced to the point where we can start to accomplish this.
So you're really trying to get from the blood what you get from the tissue, and because we're used to getting biopsy from the tissue, we just called it the liquid biopsy. But you're trying to, like you said, emulate the findings from the tissue from the blood.
Exactly, because as you know, as cancer grows, there's cell turnover, and it turns out cancer actually secretes or sheds nucleic acid into the blood, which can be recovered from the plasma compartment of the blood. And so if we want to genetically define a cancer, to look for genetic vulnerabilities that can predict response to different cancers, we actually can get that information from the blood at this point. And so it's taken a technological advance over the last few years to allow the sensitivity necessary to be able to identify and characterize, the nucleic acid that's present at really minute quantities in the blood. But now that the technology is here, you and I can discuss how the clinical utility has started to develop in this field, which is, slowly moving, but surely moving liquid biopsy into standard of care.
The first thing that I want to just talk about some practicality of things. Like, I mean, how much blood do you actually need to do the test? And then what is the test that we actually do? I mean, not to delve into so much detail, but like, what is the test? Are you looking for DNA, RNA? I don't know, what are we looking at?
So those are good questions. So those represent pre-analytic variables that need to be carefully controlled. So right now, we need a significant blood specimen. You would need at least 10 or 20 milliliters of blood. What we do is we draw the blood into a tube that actually contains preservatives because we want to make sure to maintain the nucleic acid in the plasma compartment. If you don't have preservatives, then there are also white cells in the blood that can break down and release their DNA and RNA. and contaminate the plasma compartment. So for liquid biopsy, you need special tubes that fixes the white blood cells and prevents their degradation. So, and you need at least several nanograms of nucleic acid from the plasma compartment. So that ends up, it depends on the tumor, because as you know, tumors shed DNA and RNA at different rates depending on the tumor type. But in general, 10 to 20 milliliters of blood is harvested into special tubes. When we receive it at the lab, what we do is we spin these tubes, which allows us to separate the blood from the plasma. And we also isolate the buffy coat, which is a layer of white blood cells.
Really interesting.
Yeah.
And you know, you mentioned shedding and not shedding. So I think what you're alluding to is some tumors, you easily can detect the tumor cells in the blood, and some tumors are not. So what can you give us maybe a couple of examples of tumors that are shedders and ones that are non-shedders, I guess?
Well, yeah, you know, characteristically, lung cancer, for example, is an example of a tumor that has a high turnover and sheds a lot of nucleic acid into the peripheral blood that can be detected. And therefore, you know, many of the actual studies and the technology is furthest advanced in the area of lung cancer. Colon cancer would be another example of a high shedding tumor. And then on the other extreme, right, would be brain cancer. So any kind of CNS tumor tends not to shed all that much DNA into the peripheral blood. So there tends to be a range. And you know, as such, if you look at the overall rate of cases where you can recover enough tumor DNA to do the test, it's about 60% of cases shed enough DNA into the peripheral blood in order to do the testing. If you look at lung cancer, you know, that rate's closer to 90%. You know, colon cancer, 85%. Brain cancer, I think it's probably less than 50%. So it's a big range, and as technology evolves to be more sensitive, you know, these differences will be mitigated somewhat. But the technology appears to be most sensitive in, you know, lung and colon cancers, for example.
That's really interesting. And I know me and you talked a little bit before we came on the air, if you will, and I've asked you if we can like depict on a slide or two a couple of the challenges when it comes to liquid biopsy, because if you know, for maybe if I'm just thinking about this, like I would assume, I guess, if there is a tumor, if there's cancer in the body and there's a tissue somewhere, that I should be able to find something in the blood if my assay is sensitive enough, to your earlier point, right? If it's sensitive enough. So when you don't detect something in the blood, the possibilities are either there's no cancer or the assay is not sensitive enough that you're able to detect. So maybe you can, I guess, take us through what are the challenges of the liquid biopsy and what you and the team have done to try to overcome some of these challenges.
Yeah, I think that's a very important area. And just to clarify, when we say liquid biopsy, you know, it's such a generic term. It really can be applied all across the cancer spectrum. So we have many, you know, institutions and companies that have developed screening liquid biopsies, trying to detect cancer at an early stage. And what we've been working on at Caris for our initial liquid biopsy launch is profiling of established cancers in order to select the best therapy to treat those patients. You can also use liquid biopsies to look for resistance mechanisms. So after the patient's been treated for a while with a therapy, sometimes the cancer progresses due to the evolution of a resistance mechanism that can be evaluated from the peripheral blood. And then, you know, finally, MRD testing is an evolving area that, you know, would be utilizing the same technology that we're talking about with liquid biopsy. So I think, you know, you raised the kind of the issue of,
and you know, Matt, actually, it's you know, you and I have the same interest in malignant hematology, and whenever we talk about MRD and minimal residual disease, like at least in my brain, I've always think of lymphoma and leukemia and those ones, and suddenly nowadays when you talk about MRD, we're talking about solid tumors, which is, I mean, honestly, when I did my training, this would have never been heard of. MRD for like a lung cancer, it would be crazy if you say that.
Yeah, and many of the same principles apply to solid tumors that they do for leukemias and lymphomas. So, we know, for example, in acute lymphoblastic leukemia, following induction therapy, if you're MRD negative, meaning you have less than one detectable cell in 10,000 following the therapy in the bone marrow, then you actually have a good outcome. You have a good prognosis, and therapy can be downregulated a little bit. If you do have detectable cells at the end of induction, well, then you probably should intensify therapy. And so this has been established and proven with prospective clinical trials, both in the adult and pediatric settings. And now even in the leukemia lymphoma realm, we've incorporated NGS testing to identify MRD. And so it's a really exciting area, and many of the same principles apply for solid tumors. And fortunately, we now have the technology to begin to be able to detect the DNA shed by solid tumors to follow these cancers as they evolve in the face of treatment.
So show us that like I think sometimes if anybody is listening to us and taking a nap, now you're going to wake up because we have a couple of nice slides for you. But really just depicting the challenges and how we went over it, I think would be pretty nice to our viewers. This is another emphasis in our disclosures, by the way. Yeah, go ahead, Matt.
Well, so the liquid biopsy technology, in order to do profiling of cancer to select the best possible therapy, has evolved quite substantially. There's several FDA approved liquid biopsies on the market, but there are some technological challenges that still need to be surmounted with the technology. So, for example, we talked about the non-shedder problem, those types of cancers that don't shed a lot of DNA into the plasma, and therefore you cannot get a test result. You need to actually go in and get a tissue specimen from these patients. For example, pancreatic cancer. Pancreatic cancer often is a challenging biopsy to get, but it doesn't shed a lot of DNA into the plasma. And so improved technology to address the non-shedder problem would be fantastic. And so one possible approach to that we've taken is to not only evaluate the DNA in the plasma, but also the RNA. So it turns out, and much to my surprise, that the cancers not only shed DNA, but shed a lot of RNA. RNA is typically thought to be a more labile molecule. I would have expected that there wouldn't be much RNA in the plasma, but there is actually, and it can be recovered and represents a sort of natural amplification of the DNA signal. So if we would like to identify, for example, a KRAS mutation in pancreatic cancer, but really there's not enough DNA shed to qualify for liquid biopsy testing. The RNA takes us above that threshold, and you can still sequence the RNA, you can identify specific mutations in the RNA, and so it represents a natural amplification of that signal.
Interesting. It is really important. I mean, I think if I were a DNA, I would be jealous of the RNA. There's a lot of interest in the RNA nowadays. It's like, it seems like, and I think you bring up a good point that sometimes there are certain fusions or molecular aberrations that just DNA sequencing simply fails to identify.
Exactly. So the RNA is really the best way to identify fusions in an unbiased manner. And so these fusions are secreted into the blood and be recovered by testing both the DNA and the RNA. So it increases the different types of biomarkers that are necessary to identify in order to choose the best possible therapy.
What about this chip thing? I mean, we hear a lot about chip and this clonal hematopoiesis and so forth. Let's try to simplify it a little bit, and why is it really important?
Well, yeah, it turns out to be very important. So if you're identifying mutations in the peripheral blood, you need to know the source of those mutations. And so you might assume that all mutations in the peripheral blood are coming from the tumor, but that's just not true. Actually, mutations can be derived from a variety of normal tissue sources. And one common one that ends up contaminating the peripheral blood is white blood cells. So as people age, they develop mutations in their white blood cells that don't necessarily cause cancer, but are found in genes that are commonly associated with cellular proliferation and inhibited differentiation. And they are also secreted into the plasma or shed into the plasma. And so if you're looking in the plasma of peripheral blood to try and determine whether a mutation is from the tumor or from white blood cells, you really need to do sequencing of the Buffy code or the white blood cell component of the peripheral blood specimen. This is really the only way to distinguish the two. And it would be very important to be able to make this distinction. You don't want to identify a mutation and start to treat a patient and then have that mutation turn out to not even be found in the tumor. And so that's something that we've done at Caris for our liquid biopsy, is incorporated sequencing of the white blood cell component in order to differentiate whether a particular mutation is derived from tumor or if it's derived from the white blood cells. At the same time, if you're sequencing the white blood cell content, you can determine whether any particular variant is somatic or germline, which also has clinical implications. And so right now, the existing technology, if you're just looking at DNA, if you're just looking at the plasma, you identify a mutation, you really don't know the source of that mutation and whether it's somatic or germline.
And Matt, I mean, maybe just a little bit of practicality. I mean, this done like automatically, or there's more other, like, when we sequence the Buffy code and trying to look at a particular mutation, this is an additional step in the sequencing. I guess I'm trying to get, does it really add time to the turnaround time because we're doing this? So instead of, let's say, returning the results in 5 days, now it's 6 days or 7 days because we have to do the Buffy code.
Yeah, they're done in parallel. So it doesn't add any turnaround time to our test or anybody else who would do this kind of approach. So it's really a function of taking a peripheral blood specimen and dividing it into its components and treating each component as a separate analyte. So we're dividing the peripheral bloods here at Caris into the red blood cells, which we discard, to the white blood cells, which we then prepare a library and do sequencing, and then also to the plasma compartment, which we prepare a library and do the sequencing of both DNA and RNA. And then bioinformatically, we actually utilize all the results in order to characterize all of the variants found in the plasma and let the oncologist know whether these variants are significant for patient therapy or significant for, if they're germline, for the necessity for family counseling, for example.
Yeah, that's really important about the germline. So then you have this third component on the right side, this false negative compared to tissue. And I wanted to explain this to us because, again, in my mind, I'm thinking, we in order for us to buy into the liquid biopsy and its importance, we have to be at least as certain as possible that it really reflects what's going to be in the tissue, because then in the future, you don't need to do an invasive procedure, especially in scenarios where it's difficult to get a biopsy. So what's the concordance and how do we assure that the concordance is at least high enough? Maybe it's never going to be 100%, but close enough.
Yeah, well, so we did sort of a meta-analysis where we pulled all of the published trials involving liquid biopsy when they were compared to their tissue counterparts in order to actually determine the sensitivity across different platforms. And so this represents a number of different liquid biopsy platforms, both from industry as well as academic. And really overall, you can see in that middle column, and actually I have another slide, I think, that makes it bigger. Yeah, and so you can see that, well, the specificity is very high for all of these platforms, meaning they rarely have a false positive. The sensitivity is actually ranging around 50%, 57% if you average all of these and weight them for the number of specimens. And so it really drives home the point that many of the validations that have been performed don't actually compare liquid biopsy to tissue when reporting their sensitivity. They're actually comparing liquid biopsy to another orthogonal test on the same liquid specimen. But when you compare back to tissue, overall in the field, the sensitivity is low. And this is another area where RNA is going to make a big difference. It amplifies the signal naturally, and it's really increased the sensitivity for our test here at Caris, sort of to the next level. So getting close to 90% sensitivity when we compare back to tissue.
And do you think, like, do you think this is really because of the RNA? I mean, because we're able to do the RNA, that's really by itself just shot up the sensitivity significantly?
Well, there are several other factors involved. First of all, for the first time, we're actually including artificial intelligence in the bioinformatics pipeline. It's as a mechanism to filter the signal out from noise.
I'm trying to think, I think this is really pretty interesting. The sensitivity is pretty high, and I think I'm presuming that the increased sensitivity compared to what's reported in the literature stems from the fact that we are able to do the RNA-seq on the blood. Am I off, or am I getting this right?
Yes, no, you're right on track. It's actually multifactorial how we actually can increase the sensitivity. So one factor is including the RNA, which really amplifies the actual signal. Another part of it is that for the first time, we're using artificial intelligence as part of our bioinformatics pipeline that's been specifically trained on amplifying this signal. And really, a third part really is utilization of the latest sequencing technology from Illumina. So we incorporate the NovaSeq system at Caris, and we do very deep sequencing such that it really assists with the sensitivity of the test.
That's great, and we can maybe take the slide out, Matt, the literature review. But that's really, I think from a liquid biopsy perspective, I'd like to spend the last few minutes before we part ways. I don't know, maybe what are the pitfalls, if you will, like if you're trying to think, what are the shortcomings of a liquid biopsy, and maybe we can finish, me and you, in projecting what the future holds for the liquid biopsy in cancers.
Well, I think, one of the pitfalls that I see is the clinical evidence base is very new. And so determining really the right clinical time point to utilize this testing and really the clinical significance of the results is still being established. So there have been several prospective trials that, have established the clinical utility in certain specific areas. So for example, the BFAST trial, looking at ALK fusions and ALK inhibitors, or like the SOLAR-1 trial is showing that, PIK3CA in, targeted agents can actually work equally well whether you test in the tissue or the blood. So really that kind of clinical evidence base needs to be more fleshed out, across cancer spectrum. I think that's something that's really going to have to be addressed quite substantially over the next few years.
So I thought that me and you, Matt, should probably finish by, putting our futuristic hat and tell viewers and listeners what we think the future will be. I don't know. What is the future? You go first, and then I'll tell you my thoughts, and then we'll conclude.
Well, this represents a revolution from my standpoint in terms of laboratory medicine. So historically, for the last 100 years, my specialty of pathology has utilized tissue as well as microscopes, and a very deep set of experiences to identify and characterize different human cancers. Now we have the opportunity to do this all from molecular data. We can put away the microscopes potentially, and we have the opportunity to not only determine the best therapy based on genetic vulnerabilities, but utilizing machine learning approaches, we can actually determine a diagnosis for patients from a blood specimen. And so the combination of being able to potentially identify cancer at an earlier stage, as well as provide a diagnosis and therapy choice, I think is going to completely revolutionize this area.
You know, and I predict we're going to head there. I think it's going to take a little bit of time. To your earlier point, certain studies need to be done just to figure out what to do. But you know, remember when I was in fellowship, we used to say, when tumor is the rumor, tissue is the issue. And I need to find a different slogan. Not tissue is the issue. Blood is something. But yeah, I mean, I do think that liquid biopsy is going to be incrementally used. I really find a huge utility for it in scenarios where it is very difficult to get to the tissue. And I think we can think of so many examples of doing that. The other thing where I believe it has a lot of utility is in not necessarily just relapse disease or detection of recurrence, but sometimes it's very difficult to get tissue in relapse disease because the patient is frail, is sicker. It's difficult to get in, and you don't want to waste time to be able to set a procedure that sometimes could take time logistically and could be local anesthesia, general anesthesia. I mean, who knows? And you can get just 2 tubes of blood and be able to be sure. My major concern is the overdiagnosis, or like if you really, you know, sometimes if you detect the disease early on, do you need to intervene right away? Like even if you're early detection and you find something on the molecular level, there is no question it means the disease is going to come back. But I worry if we start early on of the treatment, we may not need to, and waiting to start treatment might help because new treatments might emerge, new things we might know that you know, waiting this year or a year and a half until something happens. So I think that's really where my issue is. I feel we still need to know whether intervening early is important or not. And to your earlier point, clinical trials are going to be needed for that.
I totally agree. It's going to be incremental. There's no question. And already there's many assumptions being made about the way people are utilizing these tests. For example, I've talked to oncologists that will order both the liquid biopsy and tissue at diagnosis because of the perception that it increases the harvest of possible actionable biomarkers. But when I ask what happens if you have a positive biomarker in the blood but not the tissue, will you act on that? You know, generally the feeling is that, oh, well, this represents a situation where there's heterogeneity in the tissue. And we haven't sampled the right part of the tissue, but there's part of that tumor in the tissue that has this biomarker and it's getting out of the blood. That's kind of an assumption that's being made in the community right now that I'm not sure has a lot of data to support it at this point.
Well, look, this was really a lot of fun. I can't believe we spent close to 30 minutes already talking, but it's really exciting. It's talking about the future, and you know, I think a lot more information is going to evolve over the next year or so. If we have not messed things up, Matt, we may get invited next year. We don't know yet. We may get invited again next year, and hopefully we'll give an update. Thank you so much.
In Southern California, I'll be there.
In Southern California. Well, thank you so much for letting us be part of your day. Congratulations on a great conference, and until next time, thank you.
Thanks, Cgadi.